Namaskar. My greetings to both Dr. Sunita Tandulwadkar, Fogsi President, and our guest, Dr. V.M. Katoj. And also a very good evening to Dr. Komal Chauhan, who is our Vice President of Fogsi. A very good evening to our audience as well. And also everybody who has joined to the Gyan Pravah podcast series episode 94, hosted by the Clinical Research Committee of Fogsi under the dynamic and visionary leadership of Dr. Sunita Tandulwadkar, President Fogsi 2025. ज्ञान का बहता रोजाना एक नया अनोखा रंग, हर रात 8 बजे जुड़िए फॉक्सी के संग. I am Professor Dr. Surekha Taide, Chairperson of the Clinical Research Committee of Fogsi and your host for today. It is my privilege to welcome our distinguished guest, Dr. Vishwa Mohan Katoj, former Deputy General of ICMR and Secretary, Department of Health Research, Ministry of Health and Family Welfare, Government of India. Today's discussion is on a very important topic, translational research for improving health in context of mother and child. Welcome, sir. I would also like to welcome our Vice President of Fogsi, Dr. Komal Chauhan. She is a professor of OBGY at a reputed medical school at Mumbai. She is a very dynamic personality, a scholarly person with lots of research accolades to her credit. Welcome, Dr. Komal. I would invite you for the welcome address.
Thank you. Thank you so much, Dr. Surekha Taide, and welcome, Dr. Vishwa Katoj. Sir, I think it is an honor that you have agreed to be part of this very important discussion under the Gyan Pravah podcast series. And this is the brainchild of our President, Dr. Sunita Tandulwadkar. And in this year of Fogsi 2025, we are having a lot of innovative projects in Fogsi. The Gyan Pravah, then to name it, Know Your Numbers, which is knowing the parameters of the basic parameters, preconceptional, or every female should know all their livelihood so that they can have a healthy life ahead. Then Sampurna, which is focusing on the preconceptional planning of pregnancy. And there are so many other projects which are running. And this is a busy year for Fogsi. And I am honored to be part of this very important Gyan Pravah episode 94. And when it comes to research, I think everything focuses around research and how the research is going to help us to improve the healthcare. It is very, very important. This discussion would be so fruitful for our audience because healthcare and the improvements in healthcare are going to go in a longer way for ensuring and optimizing the mother and the child health. And none other than Dr. Vishwa Mohan Katoj, who has been the founder director of ICMR, where all the research and everything in the beginning starts. We are fortunate to have an ICMR wing in Mumbai also, and a lot of luminaries do a lot of important work in research. So this discussion is going to be so fruitful and so enriching. We are looking forward to hear the podcast discussion with Dr. Katoj and Dr. Taide. And the floor is yours, Dr. Surekha Taide. The viewers are waiting to hear Dr. Katoj, and I am too waiting. I'll be joining from the viewers link and going to enjoy the discussion. So best wishes for this podcast. Thank you so much.
Thank you. Thank you very much, Dr. Komal. This is 94th episode of Gyan Pravah, one podcast with special guest, very, very esteemed and honorable guest, and on different topics hosted by our committee chairpersons. So this is how our visionary leader, Dr. Sunita Tandulwadkar, holds the hands of all of us or the committee chairpersons so that they can lead from the front. So thank you very much, Dr. Komal, and thank you very much, Dr. Sunita. Now, I would like to introduce a very distinguished guest, Dr. Vishwa Mohan Katoj. For the introduction, I would just like to mention that yes, Dr. has done his graduation from IGMC Shimla and post-graduation from AIIMS New Delhi way back in 1978. He joined the Indian Council of Medical Research for Talent Search Stream Fellows in 1975, and he was then posted at Agra. He became the director of this institute from December 2001 to November 2008 and served as founder secretary of Department of Health Research and Director General of ICMR. Then he was at the Ministry of Health and Family Welfare of Government of India as the Secretary of Department of Research from 2008 to February 2015, and subsequently as the Nasi ICMR Chair on Public Health Research located at the Rajasthan University of Health Sciences, Jaipur. And he was also the President of the AIIMS Madurai and President of JIPMER Puducherry. Also the Chairman of the LSRB DRDO and Chairman of the Lepra Society. Our distinguished guest is currently supporting a lot of government and semi-government agencies and departments which are non-governmental organizations, as well, with a special focus on tuberculosis, leprosy, and HIV-related programs. Also environmental health, tribal health, and climate change and health. He has contributed to over 350 publications, both Indian and foreign journals, other book chapters, proceedings, and research bulletins. He is the developer of the modern method of rapid diagnosis of TB, leprosy, DNA chips, DNA fingerprinting, and drug resistant, etc. As the founder secretary of the Department of Health Research, he had the opportunity to play important role in developing and implementing 5 new schemes of DHR to accomplish 9 new businesses. And very important to mention is that he was, the person who could implement the schemes like establishment of multidisciplinary research units in government medical colleges, also development of the model rural health research units, and also the virology diagnosis and research laboratories in various states. The scheme for human resources for health research with a focus on medical college, and grant in aid scheme as well. So whatever schemes our students and faculty are enjoying, the grant schemes, that all has been the development of none other than Dr. V.M. Katoj. Sir, we are very, very fortunate to have you on this forum, and we welcome you, sir.
Thank you.
With that, I would like to go ahead and start the discussion. Dr. Komal, I would request you to join from the viewers link now. Thank you very much, Dr. Komal. Sir, let us start with this discussion.
Sure.
With your very vast knowledge and experience, sir, in this health research, specifically today's topic is about translational research and how we can associate it, link it with the maternal and child health. So that is our discussion for today. So first of all, with your experience, sir, our audience would like to know what is exactly translational research and how, there are challenges from taking research from the bench to the community. With your research, how can we define this?
Thank you, Professor Surekha. You know that traditionally the translational research has been from a lab to community, lab to the patient, lab to the community. But it's really not that true, actually. This is even the science on the health economics, on the social behaviors aspects, and what you are doing today, the dissemination of knowledge. This is all, a part of this knowledge is part of the translation. Because the technology per se, the molecules per se, or the drugs per se, they can achieve very minimal, actually, if they don't reach the people, actually, and the people don't use them. So I think the translation is a very broad term, as you look at the patient part or the healthy human population part, it is the entire, physical, medical, mental, social, all well-being, actually. So I think it's not only the laboratory, it's a lab, and the knowledge related to the society, knowledge related to the attitudes, and economics also. That becomes a deciding factor for implementation. So that all, together, how it is translated into action, so that it acts for the prevention, it acts for the promotion, and that's also for the curative side, actually, which everybody is concerned with. Yes.
Yes, sir.
That's how I look at
sir,
the translation actually. Yes.
So basically, sir, there are two types of research. One which is in the laboratory,
Yeah.
sort of diagnostics,
Yes.
drugs, vaccines, and then we want all this bench research to go into the
Yes.
community and help
Yes.
the community for its promotion of the health. So basically,
Yes.
that is the link between the two. That is what I understand. So,
Yes. You're right.
sir, you must be understanding that we all understand that there are barriers when we want to take this kind of research and implement it so that it can actually help the community. So what,
Yeah.
according to you, are the barriers, and how do you see the linkage between the two? How we can take the bench research to the community?
Actually, Professor Surekha, the biggest barrier is the mindset actually. So, if you look at any society, every society has to evolve. They have to create their own technology actually. Even very tiny countries like Cuba could achieve whatever the major countries couldn't. So that means, in terms of the generating their own knowledge, taking to the people, they did it. And the same, we did it also when the times of the Shushruta, Charaka, we generated our own knowledge, our own technologies, our own ideas. And the clinicians, particularly in India, have been doing that for all the time, even as in the modern allopathy. See, they have been coming up with the new regimens, they've been coming up with the new intervention methods, new diagnostic algorithms. So that has been happening all through. But the biggest barrier has been in terms of the innovation of what you could have done in a much bigger way, which we didn't do it actually. Many innovations happened in India, even for the treatment of leishmaniasis, your in vitro fertilization by Subhas Mukherjee, it happened all in India actually. And this happened even before the Nobel laureate person did it actually. So, but it couldn't reach actually. That was basically our mindset issue actually. And that mindset issue, how it broke in during COVID period, we broke it totally. We could accept our own technology, we could take that as a front runner, and we could do it actually. So I think it has been biggest barrier has been the mindset of the user community. That means the public and also the doctors, both actually. They are the two deciding features actually. They didn't have a confidence in their own themselves for quite some time actually. So I think that's the main barrier I saw. But that's breaking actually. So it is a thing perhaps now it is changing very rapidly. That was the time when I was here. I retired 10 years back. So till that time, that barrier was a very strong barrier. It is still there, but not that strong. Yes.
Yes, sir. Actually, I think it's a very good example which you have given, the
Yes.
trust, the COVID
Yes.
vaccine itself. I think that was
Yes.
the icebreaker when people
Yes.
started accepting our own technology, our own
Yes.
Indian technology, our
Yeah.
vaccines, our drugs. So
Yeah.
all the quality issue, the trust issue has come up. The
Yeah.
icebreaker is there, and we are now
Yeah.
accepting our own thing. So very nice
Even
example.
Professor Surekha example was because I was a secretary for a long time, and they're taking direct decisions, helping the government take decisions. When the swine flu came in 10-11, we could 6 vaccines we could come out within 6 months. So the people were ready at that time also. But
Yeah.
pro takers, so point arises. It is a taker
I
actually.
think the
Yes.
lot of policy and the administrative,
Yes.
approach is needed here,
Yes.
which is now there. So
Is there
that's why
now,
I think,
we have a confidence now actually. Yes.
okay, yeah.
Yes.
Sir, you have done a lot of work on tuberculosis, on leprosy. We would like to know from you how the journey was there from you, from that research, and of course you have led a lot of research collaborations with medical colleges as well through
Yeah.
your long duration as a secretary in health research and also as the ICMR chief. So I would like to know your story, sir, about the tuberculosis and
I think I'll be
leprosy.
very brief on that, Professor Rekha. I joined ICMR in 1975, and my wife also was a batchmate. Actually, there was 12 people selected in the first batch of talent search scheme, which you read it in my biodata. And the idea was very simple, actually. The then government wanted to select medical people directly and take them to science, actually. And through a very rigorous competition, we should be all-rounder and train in also everything. So our journey began like an all-rounder. Whatever specialty you choose, it was meaningless because we were trained in almost everything. So that means you should have the capacity to think and analyze and tackle any condition. They're like on a civil service mode, actually. So the medical people with the same level of competence as the civil servants have. Anyway, But the initial parts, when we choose the institutions, we choose Agra, Jalma, that is the institution created by Japanese for leprosy actually. And then we expanded to tuberculosis, other infections. Now, there we choose the targets to improve the diagnostics, improve the therapy, to monitor the transmission. So we were looking at the new tools, developing our own tools, which were not done by anybody. There was no copying of anybody. So our discoveries may not be of that great time actually, but they were original. They were not done by anybody. So the molecular probes, the chips, everything created by ourselves. And so whatever success was our own. So we gave, that confidence of coming with our own diagnostic methods, our own targets, then even our own therapeutic regimens, and then you also seek the translation in the community actually. So there was no gap actually. That means doing a high-end science, but directly with the people actually, directly working with the people. And the same time working in collaboration with the state medical colleges in the elite institution like AIIMS also. See, the mycobacteria at that time was a defunct. Very few places people were working on that. Now there are hundreds of labs. And then we created our own repository and kept on networking medical colleges. And that it started with 5 and it was 38 at the end of 10 years actually. So building a coalitions and not being very visible, letting other people do their part, and so that they should not be scared of you. They should not feel that you will snatch their credit actually. So I used to call, okay, you send your MD students, let him or her stay in the guest house and do that part. Our interaction was they will test our probes, but then they will publish their own work actually. So it was a mutual gain. And VM Katoch, we were not visible directly. We were not saying that's your work, you publish. Okay. So that experiment of being a catalyst actually, that shaped my personality, shaped personality of my wife. So we could create the groups actually on a subject, on tuberculosis, on leprosy, the areas we chose. I think that evolution was a God gift, and that shaped us and shaped the future of the many things after that. Yes.
Yes, sir. I think that gives a message that
Yes.
when you're as a trainee in the medical college, we have a very wide approach. We are taught so many things, but we do not know our niche, isn't it?
Yes.
But
Yes.
for you could decide that niche very well,
Yes.
and you
Yes.
got that opportunity.
Yes.
And so expansive work. It's to find out how many new tools you have given. And definitely we have to choose something which the community needs.
Yes, that's right.
The need-based approach is also very important.
That's right.
Tuberculosis and leprosy was rampant at that time.
Yes, yes,
And through the last so many years of extensive work, we are able to come to this level now. We have
Yes.
some control over tuberculosis.
Yes,
And
yes.
so that niche and something which the society needs. If there is the association between the two, then success is guaranteed. That is what I learned.
No, I think, Mr. Sureka, you are absolutely right. And one more message I would tell you, that message was of a self-reliance. Even though our was a ICMR institution, but there was not much money at that time, I tell you. So it was basically, we were ICMR institutions, we were trained by ICMR, and that's our shadow, they are our parents actually. But then we started competing for the grants outside, like from DBT. See, my wife is a clinician, but most of her work, even her clinical work, public health work, was funded by Department of Biotechnology. My work, my funds came from DST and the DBT then. So question was, we were not a parasite on our parents actually. So we were not, we didn't grow on assured money. So later years, when there was a lot of more money, the productivity was not that parallel actually. Because if plenty of more money doesn't mean better success, I tell you.
So you have to value that money. You need
Yes.
to find out from where to get the grants, isn't it, sir?
And compete for it.
Yeah,
And now,
compete for it.
And now at the moment, the health research in India has always been funded by at least 8 agencies. And now those 8 agencies give a lot of money actually. Now the money is plenty. It was not that scarce at that time also. See, but the DBT money, ICMR money was used to be distributed in many things because ICMR was known to everybody. So everybody used to compete there. Now, DBT, DST are science agencies where the selected number of people will go and very few medical people will go. So we went there and we got the money. We competed for it. But the goal was to create a technology. Goal was to create a vaccine or test a vaccine. No. You see, both of us are very Swadeshi looking actually, except for one or two. I think hardly what I think out of my 25 projects, one was a Indo-French and one was a WHO back project, but they are of a very small nature actually. Compared to the money given from Indian agencies, there is a smaller one. We focused on focused on a Indian money, and that money is a Indian money, and that you're answerable to your own country actually. So I think our approach was that way. Yes.
Over the years, sir, now so much grants is being provided by ICMR. I myself, when I was younger in my early career, I used to think, okay, where from we'll get the grant. But when you search for the resources, there are n number of organizations which can give grants to our professors, our academicians. So would you like to highlight a little bit on that, sir? Mention few more organizations.
I think mention very. I say very simple. If you want to work on the experimental side, there are a number of agencies. Like ICMR is one of them. Then is the DST. I prefer the DSTs first for the original ideas. Then if you want to translate immediately, Department of Biotechnology, the second choice. DRDO Life Sciences funds that. CSIR funds that. Okay. And then this way you keep on counting. There are about 8 national agencies which give money for science. Okay. For the medical science, biomedical science. And then actually the programs give money directly, like TB program, the mother and child program, on the social welfare, they have the grants actually for the implementation side. So depending upon what you want to do, there's a money available actually. So the question is the money is now has been in plenty. Even it was not scarce earlier also, I tell you. We had a more of a tubular vision actually. We were not competing that hard. Yes.
And for students also, sir, such a lot of schemes are there. For the students, the STS scheme is there. Very nicely, the students are able to, even for the postgraduates. So would you like to share something about these 2 schemes? I think it has come up in your tenure only.
No, STS came before me actually. It got expanded during my time, but it was there before me also. See, that scheme, actually even that's for undergraduate students. You start thinking at that time, for an idea which you can implement in 2 to 3 months. So you write a project or maximum 6 months. So that means that shows the skill of the young student to collect the idea, analyze a point, and do something maybe on the data which is available already. So that you may not be experimental work. It could be a clinical data. It could be the data from the institution, labs, anywhere. So the point is they start becoming aware of a Indian problem. Okay. So and they start looking at what you can do in this small time actually. Same way for the postgraduate, there are grants from not from ICMR, there are grants from other these are all science agencies actually. So they fund them. Okay. So that means you compete for their thesis actually. You give them their grants for thesis. The grants for thesis from that, even the associations also. Maybe the Fogsi also may be giving, the IADBL gives actually. So the IL gives, the several agencies give, several associations give. So I think the money is not that difficult part actually. Yes.
Sir, just following that thread, for the postgraduates or for the undergraduate, you said that simple projects which are useful to the society. Any other message you would like to give? What kind of projects get funded as far as the postgraduate thesis is concerned? Are they well-written ones, or do they follow a good research methodology? What are those which are funded? If you want to write a proposal, how should we go about it?
Yeah, I think, Professor Sureka, very simple idea is, if they say is to be competed for that funding from the national agencies, it is very simply how nicely it is presented actually. That means what is the new in it? And what even that with limited data, if that happens, what will be the addition to the knowledge? So the persons that a skill of bringing out what new will come out of it. Okay. Maybe it is a new applied knowledge. Maybe it is a knowledge which is not applied in that area, so that it becomes of a public health importance. So, and it is something, that data becomes useful to do some more work. Okay. So I think these 3 questions, if the student puts in that thesis, then it becomes a novel thesis actually. And so if, for example, thousands of students are passing out in PGs actually. If even 1% of them have this novel idea, others are just doing a formality actually. But if the 1% students are doing that, there's a big number actually. And when they become the lecturers, when they become the lecturers, the assistant professors, they become the better teachers because they start thinking better actually. Yes.
Yeah. And the scientific rigor, is that
Yeah,
also
yeah.
taken into consideration? Like
Absolutely,
how,
absolutely,
yeah,
absolutely. The design of the study is very critical actually. Your question and then the design. Yes.
the
And then
scientific rigor, what they are following, how they are
yeah.
reporting, and all
Yes.
that is absolutely very important when
Yes.
you are
Yes.
writing
Yes.
it.
Yes.
So
Absolutely.
I
Absolutely.
so I think that is a good message for the postgraduates, because
Yeah.
lot of schemes are there for the postgraduates, but very few are
Yeah.
applying because
Yes.
probably they don't know the
Yes.
awareness. So through
Yeah.
this podcast, probably we can give the message
Yeah.
that
Yeah.
yes, there are a lot of
Yeah.
schemes.
And Professor Sureka, one thing which is a negative part, I don't want to highlight that way. See, remember the British time, there were a few medical colleges, and they were all very good. Now in the 50s, 60s, 70s, the three generation, I followed, I have data on that. Almost every medical college in the country, anyway, where the periphery, in the center, or the many places, they were all teachers were doing some science. They were thinking actually. They're publishing something, they're presenting something. So they could train their students also like that. Okay. Now those students lasted for another 10 years, So 80s, by 80s, there something was happening. By 90s, in the most of the state institutions, the degradation had occurred. Okay. Whether due to practice or due to the not a good principles being role models on the top. So, it was a chaotic after that. So next 20 years was 10, 15, 20 years were quite horrible in terms of the quality of science. So the brilliance of the people didn't vanish. It was the same. We are genetically same people. The same are bouncing back now. So, but the point was, the trainers got lost. There were no trainers. Okay? So if you are very good, many were the very good doctors. They could have the clinical skills. They can diagnose. They can treat their patient. But when they say what is new out of it, what new they want to improve, they won't have an answer to that. See, the
Yeah.
difference between a consultant and a teacher and academician is only that. That means other two components you are able to identify what more to do, okay, and why to do it. Okay? It is not from the commercial angle, not from the technology angle actually. It is from the angle of either improving the diagnosis or improving the outcome. Okay. So that analysis skill is required actually. So that is a basic skill of a teacher. So I think that's getting back actually. Now people are realizing, but still it is I think it is a diluted.
From this point of view, because I am also a lot of interest in medical research, I am the chairperson of the clinical research committee of Fogsi. So what do you suggest, sir, as a solution? As you said, okay, lot of medical education, the quality of teachers may also have deteriorated, but there are new and new things being brought up, like there is a medical education cell is there. There is now the basic course in medical research is compulsory, isn't it?
Yeah.
So such kind of things, what do you suggest, sir, that we can bring in the research, rigor back?
I think, Professor Sureka, one thing the teachers have to emphasize, that is that originality. What I'm doing, how it is better than the past. See, now if you have to comparing with the past actually. That means that I'm telling you the same question. Either, if you want to study the patient, why, what for? Something which is not information not known, is it going to be of a public health importance? Is it going to be important for introducing some new method? Or it is going to be important for introducing a new intervention method? So which will improve the outcome? Like you have a 60% outcome, you're going to make it 80%. And what you want to add actually? So if the goals are clearly identified, you need not be looking at, this is not the molecules will provide you a solution. This is not the instrument which will provide you a solution. But if they are needed to improve a diagnosis, yes, it is to be needed. If they are needed to improve a algorithm or decide a therapy like in cancer or maybe your preeclampsia, maybe other things where you want to say whether this to be given or not to be given, okay, then that serves as a platform. Achha. So question is, the goal has to be very clearly defined. So if the teachers, the teachers have experience, I tell you, even if they were not well trained, but they have a question, they know the understand, because you treat patients and you know the answer question actually. So if you tell their questions in a very good, effective way to your students are very bright actually today also. And I tell you, and ethically, there is suddenly again a back resurgence of ethics also in the students. I'm at the moment, I find last 5-10 years, I find a very sea change actually. So it is not that they're interested in themselves. For a while, the people were interested in themselves only. This generation wants their impact actually. So it is the right environment, and it's the right environment where people are proud of doing their own things actually. Well, we'll create our own thing actually. We'll create our own intervention method. May not be a new vaccine, but it is a new way of doing it actually. And actually a new way of introduction in the private side, in the public health side actually. So I think the question is the goal. I think goals are to be better discussed, coming up again and again. That will change the quality of everybody. I tell you, people are the same. Nothing has changed. So yes.
Sir, I agree with you about the new generation. They want,
Yes.
because they have come for some impact on the society.
Yes,
I find
yes.
a lot of questions coming from them when they
Yes.
want to choose a research like their dissertation or their thesis. They are very much worried. They
Yes,
come up
yes.
to the guide. So
Yes.
I think the message is purana घिसा पिटा thesis na deke. Something
Yes.
if you have new.
Yes.
Yes. We have been doing observational studies for so long.
Yes.
20 years, what were the ovarian masses and all that. We don't want that now. We want something new. I think a small build up on the past knowledge has to be there. And we need not worry about where from we should get the grant.
Yeah.
So
no, and Professor Surekha, people like you, who have a very energetic teachers. See, the whole thing will revolve around the teachers. So, for example, you write the grants, and you should give that work should be sustained actually. At the time, I remember, I was an active player actually in before 2008, and in that time, my students, whether they're MD students or PhD scholars or even the MSc students. So the topic was the same. It's one after the another. One will do on the same stage in Firozabad, somebody will do in the next place, then the third place. So likewise, 38 districts covered actually. So 38 districts covered of Uttar Pradesh and 38 students gone. What's bad about it? That became the biggest database of a drug resistance problem on TB in that area actually. So the point is, see, the question is the teacher should have a goal. Okay? And the goal has to be around teacher. And then many of those students have become a very good practitioners, like either in medical colleges or on the field or as a scientist, because we taught them the methods. We taught them how to do it. Okay? So not out 38 will go that high, but out of 38, at least 20 are quite high actually. See, so the point is teachers teach the student how to think actually. But the grants, the area should be a common focus there. Okay? And then the individual freedom to the student. No student should not be second author all the time. If a student has given his or her original thinking, then that is to be respected. Otherwise, that fellow will be a sucker all through afterwards also. He will suck the blood of his teachers, students. Yes.
Absolutely. That is what is ethics of publication ethics. Absolutely, sir. And what you have talked, collaborating multiple, medical facilities or research institute on the same thought process. Like if you take maternal and child health, there are certain areas which are focus areas. If we can focus on these focus areas. So what according to you are these focus areas? Because I have seen many a times I have gone on the website of ICMR, they are giving lot of importance to maternal health and child health. So I think these focus areas, if you can just talk about them a little bit.
See, they will be, versus Sureka, maybe more of my own perceptions, and their perception may not be correct. I mean because, God has not given anybody any total idea to only one person. So my ideas may not be that robust also. But when I looked at the mother and child health, I started as a house surgeon in gynae only. I mean, I wanted to be that way, but the ICMR didn't have only one position at that time. So then I changed my area, but it's no problem. I have no regret. So the point was, you see, the mother and child had some issues which were eternal actually. So you are battling for their mortality, morbidity, both. Okay. You want a healthy woman, you want a healthy children. That's all. Both are required actually. So, and that perspective, people have been trying. Actually, they have been trying methods. And the knowledge was not the lacking thing all the time. Okay. With the same knowledge, you look at the states like Kerala, they had achieved the same levels which the Europe had done, 30 years back. Okay. Both infant mortality, the maternal mortality. It was the application of knowledge. So the public health application of the knowledge by the clinicians and also by the public health people, that made Kerala ahead of everybody for years together. Now 15 states are in the same league now today. Okay. So the whole major part of the country has moved that way. But that time it was one state only. So what it showed was it was not the lack of knowledge. We had the contraceptives. They were tested in India, but then not uniformly applied. Okay. So women couldn't control their fertility. Okay. So the molecules were there, the tools were there, everything was there. So okay, the better and better tools also kept on emerging, but basically the application went off, despite the units being in the medical colleges. So the social behavioral science, which was the deciding factor, people stopped it. Okay. So that means that social behavioral part, that means acceptance by the community and its logistics and the cost effectiveness of what you're doing was the critical part in the women and child health. Now the interventions came on vaccination. Interventions came on the nutrition. For example, your folic acid, the vitamin B12. No, they affect the mother and they affect the child also. Okay. They affect the entire congenital abnormalities also. They decide the growth also afterwards. Now the use of the iodine as a part of the salt, that changed everybody. Okay. It affected the general population, the mother and child, for the maximum benefited actually straight away. Okay. So that way, you can keep on enumerating one after the another. Okay. Where there is a data to show, okay, when this was done, this has made a difference. Okay. And this was not done despite being there. And that's why a particular state could not do anything, because we have states which did much worse than the sub-Saharan Africa till this time, actually, very recently. And some areas within the states also much worse, actually. Okay. So we have the better than Europe and worse than sub-Saharan Africa. So that wide range was basically the application, actually. So, now with your, like this today's interaction, this you would have been doing with everybody. And with those 93 people who already spoken before me and some will speak afterwards, they have their experience to share that what can make a difference, actually. See, for example, the tuberculosis that became with the probes, molecular probes, not today, long back, actually. And leprosy also became. But the probes came, even for the PCR system for tuberculosis, came in 1989 from this country.
Wow.
But still, they were among the very first 5 in the world, actually. But there was a resistance all through, and there were no takers across. Now we have more than 9,000 PCR machines in the country, actually. The real-time PCR also. So they are available for TB right up to PSC, CSC level. Okay. And so I think it is a question of the time scale. But for the woman health, I'm telling you, the genital TB in women. Okay. We have the tools. But you look at, how are we confident of the diagnosis even today? Okay.
No.
Have the pathologists adopted that molecular probe to a in situ, which we described right in 2004, actually? So that synergy of translation and the interdisciplinarity where people should accept the new changes, I think that has been very slow. The probe for genomic labs we established right in 2000, actually. So we had our own chips for leprosy, TB, and we prepared even the chips for rice genome. There were very few, nobody were coming to work with on the human side, actually, so the point was, for the cancer, for lymphomas, 95, the DNA chips came. And there's so many panels, more than 400 panels for cancer are available, which are developed by people. But India didn't venture onto that. So that conservative attitude in the medical fraternity has to go, actually. So this is a message I would like to give you. They have to think of, they have to be confident on developing their own, because our institutions are among the best even today, I tell you. You look at the DVT institution, CSI institution, this ICMR institution, the DRDO institution, they're among the best, actually. And elite institutions also. We have the excellent institution like the Mahatma Gandhi or the Sevagram, which has the connection with the strongest connection with the people directly. Okay.
Definitely.
So point is the models are there. Yes.
Sir, talking about the same thread, you have talked about, you have established those multidisciplinary research units.
Yes.
You have been instrumental in that with ICMR and medical colleges. Would you like to talk about that so that we understand how we can use those units? Yeah,
Professor Surekha, I would like to slightly distinguish this now. The ICMR was created in 1911. But in 2008, this became the part of 2007 rather. It became a part of a department. So department has a 10 functions, and ICMR is only one of that. ICMR is everybody's name because it is a household name. It is an old name. Okay? So DHR is different. DHR is the umbrella department. So the secretary of the department is also the director general. Okay? But director general is only one thing. So 9 functions are of the secretary actually. So these units are not ICMR units actually. They are units of the Department of Health Research. Though the head is common, and
Okay.
I was upper secretary, so I was common for both. Okay. So ICMR thing serves as a science body, thinking body. Okay. So even today, this provides the thought, it provides the scientific brains. But the units are controlled by the Department of Health Research, and they are in the medical colleges, which are controlled by the state actually.
Okay.
Now, I think the chief, because this is 4 generations back. I retired in 15. After that, there have been 3 secretaries. So now the present secretary is even thinking of expanding to all. Actually, he wants his vision is to include everybody. That's even the private side also, and I agree with that. Okay. So question it will be competitiveness. These units focus on the non-communicable diseases. So mother and child comes there, genetic disorders come there. Okay. They're all there actually. And then he is also a very clear vision to make a difference to the people. So those units, like at the moment also, he had a conclave a few weeks only back, and I was invited there to showcase what they are doing at the moment. And they're making them compete with each other also. So that means give money, plenty of money is not a scarce thing, but for the ideas, the performance, they are honoring who are the people right on the top who are performing better than the others. So these units, they want a person where any department, there should be at least 3 departments working there. That it should be interdisciplinary. No, like a problem like cancer, problem like your genetic disorder, or problem like on other disorders, NCDs, other NCDs. It can't be handled by one person. Okay. So like PCOS is one example which you are grappling with. The young girls are in a very big way suffering. Everybody knows that. So PCOS cannot be handled by dermatology. It can't be handled by gynecology. And it can't be handled endocrinology alone. This is an interdisciplinary thing. Half of the things are really not known that girls are suffering. Okay. So the point arises there. You need a definitely interdisciplinary approach. Actually, you need a clinicians of 3-4 departments. You need the biochemist. You need the molecular biologist. You need everybody. Okay. So I think there even to address one question, you need an interdisciplinary team actually. So my view at that time was, and the views who supported that venture was that for non-communicable diseases, for genetic disorders, for mother and child problems, you need people we have to work interdisciplinary. It is not can't be one vaccine, one diagnosis which a microbiologist and one clinician is happy with doing it. Okay, one public health person is doing happy with it. Infections may not be all the time interdisciplinary. Though a TB-like diseases are interdisciplinary, but not necessarily. So I think for NCDs, interdisciplinarity is a must. So these units were established with that goal. So they were launched during my period, 2013 to 18. The next, Dr. Somia got them extension for another 2 years. Dr. Balram Bhargava got it for another 2-3 years. The present person is coming in a very big way, and he's changing their shape and the way of doing it. But these essentially MCDs, they were on the non-communicable diseases. That includes the mother and child health and the genetic disorders also. Yes.
So what is different in these units and the model rural research units?
Yes. See, model rural health research units, again, this is a credit I should not say. This came in I think a project led by my wife actually. She created in the field unit, problems like leprosy, tuberculosis, malnutrition in some areas she chose in UP. And she found, that if the state medical college is part of the scene, if the state health service is part of the scene, and like ICMR institution is a part of the goal, and like a good institution like AIMS is also participating, that means you identify the problem much better. Then the state decides what they need actually. So that means it is the projects where the priorities from the very beginning decided by the state. State medical college is part of the science also and the evolution also. So this will lead to a very good high quality science, but this will it will take the technologies direct to the people. So that was the model created with her own grants in Ghatampur in Uttar Pradesh. But then, later we expanded to 15 states when I was a secretary. And the present government really thought that is a top priority, that is now that's there in 33 states. So these are the units established at the CSC level, and there it works directly with the state medical college and elite institutions. So that means is a science of very high order, but it is reaching directly to the people. Like in your Maharashtra itself, their state in best unit is in Dahanu actually. That's in Palghar. The second is also coming in Bani. But these 33 units are there now in right up to Port Blair, and all one line. They're taking the technology direct to the people. So there's no gap in between.
Thank you, sir. Sir, I would just also like to ask how we can encourage our young researchers to focus on translational research, because we are talking of translation research, especially in context of mother and child. How can, encourage young researchers, according to you?
See, young researchers, again, I think the best part is if you have to give examples of living examples of the Indians, actually. Indians before, don't forget about whether it's the British time or Indian time, or right up to Shushruta time, we have a lot of examples, and actually in the science there is nothing like Indian foreign also, I tell you. But if you give due respect to the heroes all across, people should respect. That means there are a number of Indian heroes which we normally shy away from teaching actually. But that should not be parochialism. It's not like something a fanaticism. See, for example, Subhash Mukherjee was ahead of anything for in vitro fertilization. He could have got the Nobel Prize had we not destroyed him. Okay. Then Subhash Mukherjee should be taught whether he got a Nobel Prize or didn't.
Absolutely.
Okay. Purandare was, person who set the entire ball rolling, changing in for your gynae obstetrics. Same from the persons who were the second person who headed after Shirodkar was there. And there was one person, actually one from the Tamilian who.
Yeah. Shirich was also there.
After Joseph Bore, in 1960, he reviewed the entire health schemes in the country. I'm just forgetting his name. But the point was, we have a lot of Indian examples for every disease. So the Indian example, you must be, when the teachers in their general talk should talk of your Indian heroes. So Indian heroes who have created something. So that means they are living examples. It's nothing theoretical for the people. Okay. And that gives you a second confidence to the people. Well, he could do it, she could do it, I will do it. Okay. Because I'm not an inferior race. I should not copy anybody. Okay. I should not be talking wrong of anybody. I should not be, when I say I'm against British or I'm against American or anybody. No, not that way. But I should have a confidence in myself. Okay. My forefathers could do it. The recent generation could do it. I will do it. Okay. So the basic question is of a motivation actually. And it is not fanaticism. It is based on the actual work done by people. So, and we have a plenty of heroes to give examples, but they should not be theoretical heroes to call, we're talking, linking to religion, caste or area. No, nothing like that. It should be purely on a Indianness. Okay. And at the same time, where we globally stood. And today we can do how much we can do. So I think, making the students a very realistic, that means number one, their life, they have gotten only once. And they have the opportunity to leave an imprint. An imprint like people who existed on right here actually. Okay. I mean, like ICMR. ICMR has, I'm only a person headed for 7 years actually. But ICMR has been headed by so many people from the 1911 to this date actually. All of them have contributed actually. No, not a single person matters actually. So the point is, and all of them were heroes in their own light actually. No selections were that were done otherwise actually. So the same story applies to everywhere. And gynae obstetrics also, you have your own heroes actually of contraception, your own heroes of in vitro fertilization, your own heroes of who have made a difference. Like I mean, at that time, very simple, like a cervical incompetence, the people could not free actually. They were treating it in a funny way. They just tied a good thread and changed the whole story actually. So the point is a different thinking for a same solution, same problem. So I think
we have to think about innovations. That is what you're talking about.
Innovation and a solution which is my own actually. I own it. Okay. And that solution gives a improvement. Either it radically changes something or it gives an improvement. Okay.
Improvement. Maybe a small improvement from maybe 20% it has gone to 30%, something like that. Diagnostics, treatment management, something which innovates. So make in India.
Yes.
That is the message. So in
Yes.
Foxy also last year we had this workshop on making in India, and we could identify lot number of innovators, especially in OBG, because I am from OBG. I could, as a clinical research chairperson, could identify so many people who had used it, different suture material or
Yes.
Gideon stitch. I can remember one person from Madhya Pradesh was using the Gideon stitch to control the PPH. So innovate new things in your own practice, clinical
That's right.
practice, and publish.
That's right.
Publish that.
That's
Because
right.
as you said, we
Yes.
will be remembered in print,
Yes.
isn't it?
Yes.
When we
Yes.
go away.
Oh yeah, yeah.
Yeah.
That's how we have. When you take example of this, our old legends, Shushruta, Charaka, and on them, the best books have been written by an allopath. Actually, Beliathan was one of the best cardiac surgeons we had. Actually, he created the bulbs. He created so many other things also. But the best books on Charaka and Shushruta are written by him. And where even those inventions by these legends thousands of years back were correct, he has analyzed them. Okay. So I think the question arises that science has no boundaries. Yes.
Yeah, thank you so much, sir. I think I can go on and on with this with you, because this is the topic of my interest as a medical teacher and as a researcher. I would really like to go on, and with such an scholarly person like you, inspiring person like you, who can guide us through generations. I think your work has been so inspiring. If young researchers can be asked just to go through your CV, I think they will learn a lot. So I would like to have some final message and final thoughts from you, sir, regarding these translation research and how it can be taken up to policy, and how all our youngsters can be inspired.
Yeah, I think, Professor Surekha, despite you wanted it to be done in some structured way, I think my way of answering has made it slightly absurd.
No,
but
I
it's
think I
fine.
have enjoyed it, because we had decided something, but I think
Yeah.
both of us being,
Yes.
teachers, we
Yes.
could
Yes.
strike this balance between and take
Yeah.
forward this very good
Thank
podcast.
you. Thank you very much. No, certainly no. I don't think anybody has a final solution on anything, which includes me also. But the way I was sharing the experiences, one more experience which you wanted me to talk about was how to translate to the policy, actually, because long years I was in the policy. See, after I moved to Delhi, it was for 7 years was creating a policy, helping the policy, and being a part of a system where the more than one department will be involved. Then actually the issue, even after 10 years after that, again has been the same story. So point is how you change the policy, how you affect the policy, that depends upon a very sustained work, actually. So I think, yes, the youngsters must think, if they have a determination, they can do it. And the best way is, persistence with it, generate data, collect evidence which is from multiple centers. So that means you learn to collaborate, actually, learn to respect the work of others, learn to say that, no one single discovery will change the whole world. You may get a Nobel Prize sometime, but that will not change the public health policy, actually. Public health policy is a part of a socio-behavioral change in which, the bureaucrats, the politician, everybody is a part of the story. The professionals are a part of the story. So the message to the youngster is, if they have a dream of something long, they want to make an imprint, actually. It's okay, create something original idea, which is changes as a doctor changes the practice, the clinical diagnosis, management. But then you think this can make a bigger change at the community level, or you get the position like a vice chancellor of a eminent university, or say director of a major institution, or maybe director general or a secretary. If you get that opportunity, then again you have to be a convincing person, and the convincing comes through a canvassing, actually, and canvassing is to everybody. But the best targets are politicians, actually, which people don't really normally realize, actually. Most of these schemes which came out, even the virology was one of the very successful ones. That was again one of those 5 schemes which came during my period. Point was, but virology became bigger success because the public needed it. Soon after this COVID was there, everybody said it became needed by everybody. Others struggle because they don't have need, actually. So anything, like any invention which is to go into the public policy, and you think it should be done. See that first you should convince your side. That means you should organize as many as seminars, deliberations on this as possible. Then try to create a bigger groups where you generate the data across the country, at least in all corners. that people must do on that. There are a number of examples on that also, which people do. Which then if you have already done that and you're working through a good, powerful scientific bodies like IAP or Fogsi or other associations, those recommendations should also go through the government. But then you should start directly meeting the people on the authority. Actually. That means the secretaries and the ministers also, if possible. But then you start catch the MPs who are a member of the health ministry committees. There are about 50 people, and that's what I did for a couple of years, at that time, to convince them how this will benefit. They were new schemes actually, how they benefit the people across there. They relate with their public. Most of the politicians, I tell you, in their heart, they want to do something for the people because they want to live with them. They want to succeed with them. Okay.
Absolutely.
Okay. So they may have their own agenda of how to divide the people, how to win the votes and the money, but that's a part of running the politics. But they want to leave an imprint, I tell you. This is my feeling. I mean, I still rate them number one. Okay. So most of them, you can presenting to them those health ministry parliamentary committees again and again made a difference. In the end, they were supporters across the parties, all parties. Okay. So ultimately, this was not the Congress resolution at that time. Congress was which gave me the opportunity to that time to back up. I served this present Prime Minister also for 1 year. 6 years I was there with that government. 1 year I was with him also. But governments have the same agenda, reaching out to the people in their own way. So I think interacting with the politicians and choosing the member of parliament as the target. And in the state also, your own type of the people who matter with the health system. They are the must to convince them how it will benefit people. They look at the numbers only. They look at how many people, how it will benefit. Like a new technology will be introduced, how it will serve my people. That is the language they want to understand. Okay? And they back you. So that is the way of changing the policy, and policy does
Absolutely.
change. Yes, it does change. Yes.
So great message, sir. What I gain from all of this is be consistent with what you're doing. First of all, whatever you're doing, do it over a period of time, collect the huge number of data with collaboration. So you learn to collaborate, to be consistent, and then all the stakeholders, those who are important in policy making, starting from local to state to national to your leaders to, if you can talk with Dr. Modi ji, of course, those are the people who are going to bring the change in the policy. And rightly said, all number of politicians want to bring the change, want to live with what is good for society. Few days back, I had been to Mantralaya to talk with the health minister for one of the Fogsi's lead project, that is preconceptional care. And he was so happy that we want to do something pro bono. We don't need money for that. We just want that idea has to be accepted by the community. And he was so good. Mr. Ambedkar, who is the health minister of Maharashtra, took it so positively. So you should have convincing power. That is the message, sir, from this whole podcast. And I'm really thankful, sir. Thank you very much. I think we have learned a lot from you. And I really would like, on behalf of Fogsi, I would like to conclude this insightful episode of Gyan Pravah with a very heartfelt gratitude towards you, sir, for sharing your expertise and enormous experience on this topic of health research. Sir, your dedication to this is truly, truly inspiring. I would also
Thank you, Mr. Sunita.
Special thanks to Dr. Sunita Tandulwadkar also, sir, who is a visionary leader and made this platform a reality, because we have seen through this maybe a 40 or minutes of discussion how we could foster a meaningful change if we can in the minds of youngsters to take up translational research and try to change policy.
I convey my greetings to her also. This is a visionary way of looking at it, I tell you. This is a way to reach out to the people who matter, Because ultimately, our professionals have to think that same way if we want them to make a change,
So these podcasts, sir, are helping us such a lot, because I would never have had an opportunity to talk with such a person like you. But I think she has given us the opportunity to search for people and for quality, so that we can give that quality half an hour to 40 minutes to our audience. So I would like to thank Dr. Sunita Tandulwadkar also. I would like to thank the whole audience who join us and who interact with us. So thank you to the audience as well for joining, and thank you to the team for making this engagement a very important engagement to drive change, especially in maternal health and child health. So stay connected for more thought-provoking discussions in the upcoming episodes of Gyan Pravah. Until next time, let's continue to learn, let's continue to share and empower. Good evening and take care, everybody. I, Dr. Sunita, along with Dr. V.M. Katoch, sir, would like to sign off. Thank you so much.
Thank you. Thank you.